Welcome, everybody. Thank you for joining us on an action-packed evening with the election going on. This is a topic that's very near and dear to me, but I can see that many in our community are very interested in learning more about dry eye. A little bit briefly about myself. I am an ophthalmologist, and I have completed a fellowship in cornea, refractive, and external diseases, meaning my area of focus is ocular surface. So conditions like dry eye, corneal transplantation, cataract surgery, and then also refractive surgery. That includes a gamut of procedures such as LASIK, PRK, ICLs, and the long list there. So for this evening, our topic is to be discussing dry eye. But dry eye is such a vast kind of entity in itself. My goal for this evening was kind of to give a brief introduction to what dry eye is, why we should care about it, what the conventional diagnostic options and treatment options have been, and then kind of tie it in together into what's new and what's coming down the pipeline. From there, we can open it up after that. I do want to highlight, I'm going to be talking about different medications and also potential medications that will be coming down the line. And I just wanted to mention that I have no financial interest in any of the topics being discussed this evening. So that being said, I think when it comes to dry eye, one of the most important things to remember here is this condition fluctuates. And this is why it makes it so difficult, one, to diagnose, but two, to properly treat, because depending on the day, what's going on, what environment we're in, it can be bad, it can improve. And so kind of like a roller coaster here. Additionally, why do we care about dry eye disease? We care because it is one of the most common eye diseases here in the United States. And so you can see here 38 million people in the United States suffer from symptoms of dry eye. So just kind of an emphasis there. This isn't the total number of people with dry eye, people who are symptomatic. And so that is 1 in every 7 Americans. And so maybe all the symptomatic dry eye people should come together and have a voting block. And then maybe the dry eye group can have, a strength in when it comes to elections. So bad dad joke there, but trying to tie it into kind of current events. But that being said, this is an important topic. Some further details about dry eye and why we really should care. This is the most common presenting symptom into the ophthalmologist clinic. It affects nearly 15 to 20% of people in the United States. So more than that 32 million, because many people are walking around with dry eye and don't know because it's a chronic condition, but eventually it can and will become symptomatic if not treated. There's also a correlation with some of the eye procedures that we do. So, as mentioned before, I do perform LASIK, and LASIK, although it itself does not necessarily cause dry eye to form, with this laser vision procedure and some of the others, for example, PRK, we are reshaping the surface of the cornea. And so those peripheral nerves do get severed during that laser procedure, and it can take anywhere from 1 month to 6 months for those peripheral nerves to fully regenerate and our patients be able to feel the dryness. So what can happen after LASIK or PRK is that our patients aren't able to sense that they're dry, and so the dryness gets worse, it gets worse, and then starts affecting their vision or is more severe, and then patients come in to get it treated. And so this is why with all of my laser vision correction patients, I recommend after they've had LASIK or PRK, even if their eyes are not feeling dry or they're not symptomatic, they are still using the artificial tears and the lubrications for up to 3 to 6 months after the procedure to prevent this from happening. Kind of tagging on to that, cataract surgery, which is the most commonly done surgery in the United States, about 87% of people at some point in their post-op course do suffer from some symptoms of dry eye. And once again, totally different mechanism. It's not the same as, for example, with LASIK or PRK. Here, what's happening is that a lot of the post-op drops that are prescribed after cataract surgery, they actually don't lubricate the eyes. So many times patients feel like when they're using their steroid or their post-op antibiotic, they're lubricating their eyes. But in many cases, they may actually be making the dryness worse. And so kind of talking about this kind of progression. And so, a lot of times the dry eye is actually present before the cataract surgery. It just becomes more symptomatic after, but at that point, our patients are noticing it. So once again, it's kind of not clearly related to the cataract surgery, but it's common to occur after. And the other important thing here is that we're continuing to see an increase in the incidence of dry eye. And why is that? So this slide, I could spend hours talking about all the different risk factors when it comes to dry eye disease. Kind of self-explanatory. Many different medications that are taken systemically, different pills, can cause dry eye to form. Anything that's going to affect the homeostasis of the ocular surface. Also, one thing that we don't really think about is topical medication. So yes, this includes other eye drops. So patients that require glaucoma medications or other eye drops that have preservatives in them can cause dry eye. But then also we don't realize that many times we're putting different kind of lotions and creams around the eye. And so a lot of those can, as a side effect, cause the dryness to get worse. So things like retina A cream that many people may use around their eye, other acne kind of treatments as well. These can all cause dryness to get worse. And as we mature, our ability to make the different components of the tear film is affected. So this is something we see as time goes on. But recent studies are showing that kids, even as young as like 18 years of age, they're actually starting to show signs of dry eye. And then when it comes to gender, differences in hormones do affect the kind of the secretion and the consistency of our ocular surface. And so for men, changes in testosterone levels can affect that. For women with menopause and other hormonal changes as well, it can hinder or stimulate different components of the tear film. Things like wearing contact lenses. Many times when our patients are wearing the contacts, they don't feel the dryness, but then when they take the contacts out, their eyes are burning. And so that chronic kind of inflammation, because our patients aren't able to feel the dryness, leads to this cycle of dryness, and then the contacts themselves irritating the eye. We kind of hit on ocular surgeries, so the kind of the most common, and then environmental. So, some climates are dry, some climates are more humid, things like allergies. And I think the big one would be the next one. And that's kind of what we're seeing as we're more dependent on digital devices. And so whether it's you're reading a book, you're on your iPhone, or a mobile phone, iPad or computer, when we are doing this kind of focusing work, we actually don't blink as much. And so we get rapid evaporation of our tears, and our brain is so focused on what we're doing that kind of leads to the cycle of worsening. And so if you can imagine how much longer we're on screens now and how that can affect that homeostasis, you can understand why this is one of the biggest kind of risk factors. I think the remaining things here pretty self-explanatory. Different systemic diseases, autoimmune conditions, things like smoking, definitely all risk factors for dry eye. And so what is dry eye in a nutshell? Dry eye is basically loss of the normal tear film homeostasis. And so the tear film actually sits on our cornea, which is the clear part of the front of the eye. So when you're looking at someone's pupil, the colored part of their eye, you're actually looking through the cornea. And what many people don't realize is where the tear film and the cornea meet, that's about 60% of our focusing. So any sort of disruptions there is going to affect our quality of vision. And the tear film is fairly complex. A lot of people think like, oh, dry eye, no big deal. Like why, it's not going to cause any problems, but it can actually lead to severe issues that we'll talk about down the line. But it's pretty complex, and there's three different layers to our normal tear film. On the inner part, we have the mucus component. It kind of helps keep it stuck to the surface of the eye. And then in the middle, we have the aqueous component, which is a more watery, liquidy kind of component that we all kind of think is what we think of when we think of tears and dry eye. And then we have an outer component, which is made of lipid or oil. And so the purpose there is it's supposed to kind of shield the tears from evaporating. So any sort of distortion in that layer causes the tears to very quickly evaporate. So with all of these, you're kind of leading to this big picture of evaporation, leading to dryness, then leading to inflammation, which makes the dryness worse, which then makes the inflammation worse. And there's just a cycle that just continues to get worse and worse. And this is kind of that chronic disease where people feel like, I was feeling fine 10 years ago, 5 years ago, but now all of a sudden I'm symptomatic. Likely the dry eye was there, but the cycle was just starting. And just to kind of help provide a visualization, because once again, that idea that people don't think that dry eye, they don't, it doesn't feel like it's a symptomatic thing. But, when we lose that homeostasis and we start getting evaporation of the tear film. So this picture on the left, this is basically the surface of the eye, and there's a special dye here that lets us see the surface. And then there's a special light filter, so that's why it looks green. But you can see all these dark spots in the middle. This is early evaporation of the tear film. And so basically the tears are not there. Those are all dry spots. And just kind of demonstrate what that would be like in real life with vision. It's like driving on the street with a dirty windshield. It's almost impossible here to kind of see the fine details. And this is what can lead to that fluctuation of the vision what goes with dry eye. Kind of providing the big picture here. This is kind of what, when we're looking at dry eye, the two big components are the aqueous deficient or evaporative, and the many different conditions and reasons for that are listed here, as well as different kind of systemic conditions as well that can affect dry eye or cause dry eye. So when we're approaching a dry eye patient, this is kind of our major algorithm that the dry eye gurus have kind of come together in the dry eye workshop and decided on. And basically you can see here, being symptomatic or asymptomatic is important in the initial roles, but a lot of the ocular surface signs and then the testing that we do can kind of help us make that proper diagnosis of what type of dry eye this is, and then instill the correct treatment to restore that homeostasis of the tear film. And so here, once again, just showing that big picture, of this component of dry eye. It can be inflammatory, it can be evaporative, it can be from microbial, but kind of highlighted with the different colors here are the conventional treatments that we've had available and where we can kind of target and initiate some dry eye treatment and management. So with all of these, we're just focusing, we're treating kind of one of these spots. And so for the future, it would be great to be able to knock out multiple, reasons for dry eye without having to do, two or three different medications. And so that's where I see kind of dry eye going, but just kind of showing, we have some medications or treatments that we can kind of improve the oily component of the tear. We have different treatments where we can reduce the inflammation of the ocular surface and hopefully cause those glands to wake up and make the watery part. We can work on increasing the time it takes for the tears to evaporate so they last longer. And then in some cases, like we'll talk about in a few slides, there's actually microbial stuff going on that's causing the dry eye or making it worse. And so when it comes to like the real life dry eye clinical practice, like we can all sit here and talk about just use drops all day long. Your dry eye will be cured, but we also have to be realistic, but then also kind of be focusing on what the cause is here. So the diagnosis of, first of all, is it dry eye? And then what type of dry eye is it? So that way we can, with testing that's appropriate, we can make that distinguishing diagnosis. Also kind of determine what kind of severity we have here, and then enact a treatment plan that's actually tailored for the type of dry eye our patients have. So not every dry eye patient is going to be the same. And then we need good ways to be able to monitor our patients to know, are they improving or not? If they're not, we need to kind of add a new treatment option. If they are improving, definitely reassuring our patients and letting them know that we're seeing that improvement. The work that you're doing is paying off. Let's keep it going is always helpful. And when it comes to symptoms, because dryness is it's a large gamut of different symptoms, but ocular discomfort, what is that? That's things like the eyes burning, feeling sore, feeling gritty, feeling like there's something in the eye. A lot of this comes from that poor lubrication from the tear film. Fluctuating vision. So things that are common, like cataracts, that's a very slow progression. Months or years, patients notice a difference in their vision. When it comes to dry eye, this is something where the morning vision is blurry. The vision then gets better and then it gets worse. So it's that kind of fluctuation as the ocular surface is fluctuating. Things like light sensitivity, although there are other conditions that can cause light sensitivity that can go along with this. And then difficulty with that focusing and up close work because our tears are evaporating so quickly. So when it comes to enacting a treatment plan, the traditional approach, and some areas may actually, this is their technique for treating dry eye is to wait for the patient to kind of say there's a problem. Well, at that case, we missed an opportunity when the condition was moderate or mild that we could actually easily reverse it. And now we're at a severe state. Instead of preventing dry eye or looking at ways of going from moderate to mild, just dealing with the sequelae of the disease process, the complications that come after the inflammation, the corneal abrasions, and then the potential effects to vision like corneal scarring. And then, traditionally it's just start with artificial tears because they're over the counter, they're easy, low risk. But sometimes that's not really the best way to start. And we'll kind of talk about that with the different treatment options. And then many times just kind of watching patients are getting worse and worse instead of getting, a more targeted treatment approach. And so this is where it's really important that we not only diagnose dry eye, but understand what's going on with the mechanism and enact a targeted approach. So when it comes to testing options, we have kind of like traditional stuff that has been available for a while. So Schirmer testing basically looks at the ability of the eye to make that the tear film, and so it's kind of a little bit of an uncomfortable procedure, but testing, but it's not bad. You basically have a little paper. Ruler that's placed in the eye, and then the amount of tears that are secreted, usually anywhere from 10 to 15 or more is normal. We can actually see how much tears are being made. The other is, using fluorescein. So this is a stain. It's a natural stain that we have. It helps us make the diagnosis in ophthalmology with many different conditions. But basically, it lights up when we're for dry spots that are more chronic, inflammation. And so a lot of times, my patients, I'm like, okay, I'm going to put a drop in that's going to help me see the dry eye, and their immediate response is, well, I just put artificial tears in. You're not going to be able to see the dryness. But this is actually what we're looking at. We can see the more chronic stuff. So whether you just put in tears or not, this is not going to affect our staining pattern. There's also other stains like lissamine green you can see here. Then we can actually see signs of dryness on the white of the eye, and look at the overall function of the mucus producing cells. Look at the evaporation of the tear film. So you can see here on the left, this is a normal kind of tear film. On the right, lots of those black spots indicating evaporation. And then overall anatomy, are the eyelids closing? So sometimes some people's eyes don't fully close, or when they're sleeping, they open. Also, another common procedure that many people have is, removing the excess skin and raising the eyelids. And so sometimes too much is removed where the eyes don't close. And so that's a consideration. Definitely, if you're considering having any sort of eyelid procedure, if you already have dry eye, it could exacerbate and make that worse. And so these kind of allow us to make an idea of, is there dry eye? Potentially have an idea, is it evaporative, is it inflammatory, is it more aqueous deficient? But we do have other testing that are available. So we can look at the osmolarity of the tear film. So is it, too watery, too oily? We also have MMP9 testing. So this is a inflammatory tear film marker that is elevated in inflammatory dry eye. So it's basically like a quick point of care test that we can do in clinic and have within 5 to 15 minutes have that diagnosis made. And then we can also look at the eyelids, because the eyelids do contain the glands that make the oily part of the tear. So we can image them and see what state they're in, and then decide if we, a special procedure can kind of help with the oil from the tear film. So here, just demonstrating to you, this is imaging done of the oil glands of the eyelid. So this is an eyelid that's flipped down, and we're using interferometry and doing an imaging. So you can see here in this top image, very nice, oil glands here that are tracking all the way back. And then when we get into more chronic conditions, you can see there's a lot of, loss and atrophy of those oil glands. And so like this in the bottom left, this is a pretty chronic meibomian gland dysfunction. So any of the eyelid procedures like LipiFlow or tear care are not going to reverse this. Now on the right, this is kind of moderate. You do have, some atrophy and loss here, but, potential to kind of get these oil glands working better. And other testing that we have available, we can do special lab testing if we're concerned for an autoimmune condition like Sjogren's that could be causing it, allergy testing, and then also we can image the surface of the cornea. And so you can see here, this is like a topography map of the surface of the eye. And anytime you have dryness, you can actually see some irregularities. And this is something we can serially follow to additionally monitor if the dry eye is improving, is the surface looking more normal. So, of the stuff we just discussed, looking at sensitivity and specificity, the Schirmer tear testing is specific, not so sensitive. The tear breakup time, looking at evaporation, sensitive, but not really specific. When it comes to corneal staining, more specific, but not that great. We do have some good questionnaires that kind of can help us understand if you've got dry or not, but once again, a little more sensitive than specific. Looking at the overall osmolarity of the tear film, kind of in the middle there. But things like inflammatory, where we're doing that test and looking for that specific inflammatory tear marker, pretty good sensitivity and specificity. So this is kind of one of the reasons why, if you have dry eye, you want to go to a dry eye center of excellence like the Gavin Herbert Eye Institute, because we have all of this equipment available and we approach kind of the treatment utilizing kind of all our diagnostic testing. And so kind of now switching gears to what treatment options do we have available before we kind of start hitting the new stuff. Well, with dry eye, up until 2018, there wasn't much movement. Basically, everything listed here is all we had, and they had been around probably since 2005. There hadn't been much change. So you can look at about 15 years. There wasn't much movement in the dry eye realm, but it's an exciting time now because there's so much more awareness of dry eye that we're getting better targeted treatments. And so from additionally, kind of here, some other options that like looking at omega-3s. So early on, there was like omega-3s, great, it helps the oil film. And then there was a study that came out that looked at omega-3 in dry eye and had kind of mixed results. But then looking at the data of that study, so it kind of stopped people from taking their omega-3s. They found that they didn't really have a control group. They were looking at omega-3 versus olive oil. And so there wasn't really a difference between those two groups, but there was definite benefit. So there's been multiple meta-analysis studies done since that do demonstrate omega-3 supplements are actually still a consideration when it comes to treating dry eye. Another kind of mention with the conventional treatments is autologous serum drops. So this is basically eye drops made from your blood. So blood is taken from the patient. It's mixed down. So you can see here in the top right, the cells and all the are removed, and you just have the serum. This is diluted down in a sterile technique by a special pharmacy, and then they turn that into drops. And so this is the closest possible we can get to our own tears, and it has a lot of the growth factors and the nutrients coming from our body that can be helpful. That it can work a little better than over-the-counter treatment options. The downsides here is, you got to do a blood draw to get these made. They're not covered by insurance. There's a little out-of-pocket cost. And then these drops have to be refrigerated because they don't have preservatives in them. But most of my patients, if they're at home, they're putting them in the fridge, they're freezing the supply they're not using. And then when they go out, they put it in like a little like a lunch bag with some ice in there, and they continue to use it. Lots of studies demonstrate improvement with the serum tears. Another that was mentioned there was punctal occlusion. So this is basically almost like plumbing, because our tears drain through little drainage pathways. We've got two on each eye, so one in the lower and one in the upper. And so this is a little disposable, either made from collagen or silicone, a little plug that's placed. It's basically like plumbing. We block the outflow of the tears, and so the tears that you're making do last longer. There's different sizes. There's also ones that do dissolve, and so basically it's placed and over time it dissolves and goes away. There's ones that are permanent, so when they're placed in there, and either if our patients rub their eyes a lot or we remove them, they kind of stay in place. And then if this is a good technique, there's even a more permanent option where actually that little drainage pathway can be closed. So just kind of blocking maybe like half of the drainage of the tears to keep your tears on the ocular surface longer. So here's just a picture. This is the eyelid that's inverted down, and you can see this little small plug that's placed in there to keep the tears around. Now, when it comes to the eyelid margin, and we're talking about where eyelashes are, options traditionally have been warm compresses, cleaning the eyelashes. This is something that I think many don't realize, is that things like makeup are very inflammatory on the eyelid and the oil function. And so if you can think if you're using makeup for years, those debris can kind of get in the oil glands, cause them to clog, and then lead to further issues. So it's really important, that at the end of the day, all your makeup is removed from the eyelid. And we do have procedures in clinic where we can actually manually clean and get all those debris off. And there's different kind of cleansers as well. Now, getting into the procedures that we have available, there is something called thermal pulsation. So, there's 4 different FDA-approved devices here, but there's some sort of a device that actually hooks up to the eyelid, whether it's right in front or it's got a little kind of massaging sequence here that it hooks into the eyelid, warms up the eyelid, And then the pulsation devices actually go through a massage sequence to get that oil, once it's loosened, out of the oil gland to prevent that oil from sticking around, clogging the oil glands and leading to atrophy. And so these treatments are not covered by insurance, but if we made the diagnosis that it's evaporative, it's coming from the oil glands secretion issues, this is a great option to consider. And so here, just to demonstrate to you what this looks like, so this is the eyelid margin here, and our meibomian glands are kind of right behind the lashes. And so when the normal oil secretions should be very kind of oily and almost like olive oil, with chronic disease and meibomian gland dysfunction, the secretions become very thick and stick in the gland, and they're just not flowing into the ocular surface. So here, just demonstrating to you when that happens, that the secretions are almost like cottage cheese. So you can see here, we're going to use a little device here to kind of show you that. So it's just going on both sides of the eyelid, and with just a little pressure, you can see it's like cottage cheese coming out. So this should really be more like olive oil consistency. As you can see, with that being so thick, it's just going to sit in the gland and long term lead to clogging and inflammation and loss of those oil glands. And so, and here's the other eyelid, same kind of a thing here. You can see the thick secretion. And just kind of demonstrating to you, this is another video here, kind of a similar patient, but they underwent the LipiFlow procedure. And so you can see here, kind of squeezing that those thick secretions are there. They undergo the LipiFlow procedure. So that's that device that actually the apparatus connects to the upper and lower eyelid, heats up the oil glands, and then goes through a pressure sequence to get the oil to come out. And then so you can see here they are after the LipiFlow. Great graphics there. But now the secretions are much more liquidy, and there's not those thick secretions. So, instantaneously you can get a great improvement with the secretion of the oil glands with a procedure like LipiFlow. Another thing that many don't know about is that we have special contact lenses that they actually help with vision, but they also treat dry eye. So kind of the original pharmaceutical contact lens was the Pros, which came out of Boston. But nowadays most scleral contact lenses obtain the same result, and that's basically a large contact lens that's actually filled with fluid, and then it goes on the ocular surface, and it doesn't touch the eye; it actually floats on the eye. So when our patients are wearing it, their ocular surface is lubricated. So it's really helpful for chronic dry eye patients, but other patients that have systemic inflammatory causes that are causing their dry eye to be worse. And then also kind of improving the quality of vision too. Now, from 2018 to 2023, there was kind of, if we're looking at the history of dry eye treatments, there was actually a lot of movement. We got quite a few medications that became available. So there was Tyrvaya that became FDA approved. This is a cholinergic agonist. And so basically it's injected into the nostril, and it stimulates tear production. And so great option. Some insurances cover it, some don't. And so that's kind of one of the hindrances. The other thing is, sometimes it can cause, especially early on, some sneezing, but for the most part, patients tolerate it well. So instead of doing an eye drop, you kind of just spray this in the nose. There's a medication called Cequa, so kind of on the realm of cyclosporin. That's a T-mediated anti-inflammatory medication, but a little stronger dose than the Restasis that had been available. And so this kind of, with the higher dose, getting some better responses there with lowering the inflammation. And ultimately trying to improve the secretion of the tears. Also, there's a medication called Xiidra that became available. Similar kind of function to the cyclosporins like Cequa and Restasis, however, a little bit higher upstream. And so it tends to have the effects much sooner than Cequa and Restasis. So, we're looking at like 4 to 6 weeks to have a response with this medication, whereas with traditional Restasis, it could take up to 12 weeks. And also better topical anti-inflammatories like steroids like Isolvis. So the issue with steroids are that long-term they can lead to cataract formation, and then also the eye pressure going up in about 30% of people. The studies have shown with this specific Isolvis, it doesn't actually penetrate deep into the eye. It stays in the ocular surface, and less chance to have those ocular side effects. Now, In the last year, there's been even more movement with three different medications that have become FDA approved and available. The first is PFHO. So this is an anhydrous lubricant. And so, you think of lubricants, you think of the over-the-counter stuff, but with this, this is a medication grade lubricant. The other is 0.1% cyclosporin. So medications like Restasis and Cequa, that's 0.05 or 0.09. This is a higher dose, and so potential to further reduce the inflammation that's related to dry eye. And then the last is Latimer solution. So on the microbial side, we can get these little parasites that live at the base of the lashes and lead to chronic inflammation that lead to evaporative dry eye, but also cause a lot of symptoms. And so we really haven't had a good topical treatment for these medications until this became FDA approved. This is a 6-week course. You take it twice a day, and it clears all of those mites, which I'll show you some pictures of what that looks like. So going back to the PFHO, this is basically an inert anhydrous lubricant, and so it actually interacts with the lipophilic component of the tear film and helps prevent evaporation. And it actually also can get into the oil glands and potentially soften the secretions as well. And so how this differs from just over-the-counter artificial tears, first, you need a nano size of it, just like 11 microliters versus 50 that we see with preservative-free artificial tears. You get a response. The other thing is it lasts much longer. With the preservative-free artificial tears, you're looking at maybe 5 minutes, and then that starts wearing off. With this, you're talking about hours of tear film stability. It's actually able to spread much better and really kind of help prevent that evaporation. And so this, the trade name for this is MIBO. This has been a game changer when it comes to treating dry eye, especially with evaporative dry eye. Now, we kind of hit on this, but with the different, cyclosporin medications, this is an anti-inflammatory dry eye treatment. We're preventing that T cell mediated inflammatory response. And so Restasis, as you can see here, was, initially available at a 0.05% dose. Cequa was next with the 0.09, but then we ended up having a combination which includes 0.1% cyclosporin with kind of a similar anhydrous lubricant to MIBO. So you're hitting it on two ends, lowering the inflammation, but improving that kind of oily component of the tear film. The trade name for that is VEVI. And so obviously higher dose cyclosporin, but then also getting that lubrication, but not seeing an increase in the side effect profile. And the initial trials have looked really good. Now, talking about Demodex blepharitis, or that mite. So they basically, we have Demodex. It can be on your skin elsewhere, but if it sets up shop kind of at the base of the lashes, it can lead to that chronic kind of evaporative dry eye, irritation, inflammation, and itching. And so this is something that we can pick up on our exam. And in that case, this is basically a chemical that is toxic to this parasite and basically knocks them out. But because of this parasite's life cycle, that's why you have to take it over 6 weeks to really eliminate it. The other thing is a lot of times the mites, if they're in the lashes, they can be on our towels, on our sheets. And so really you've got to get everything cleaned over. And also if you live in the house with someone else, you might get treated for the Demodex, but then they may be a carrier, so it can go back and forth. So another thing to kind of consider treating everybody else in the house. And the trade name for this is XDEMVY. So in terms of diagnostics, we talked about the MMP9 and the tear osmolarity. On the diagnostic realms, the new thing is the ability to do ocular testing for allergies. So a lot of times patients present, we think it's dry eye, but it's actually allergies. We keep treating the dryness and then it doesn't get better. In other situations, we think it's allergies, but it's actually dry eye. And then sometimes it's mixed. So this is a point of care test that we can do quickly in clinic and know, is it allergic or, is it just kind of the MMP9 test? So it's basically a quick point of care testing that we can do in clinic. We kind of talked about all the different thermal pulsation devices, but here just kind of demonstrating to you it's a pretty straightforward technique. But there's also, the last few years, we had intense pulse light therapy become FDA approved. There's one device that's FDA approved for the eyes. And this kind of came from dermatology because, with rosacea, IPL has been shown to be very helpful for that. A lot of times people can actually have ocular rosacea where you're getting those same vessels, but they're causing inflammation on the eyelid margin. And so kind of definitely we see potential with the treatment of ocular rosacea, but then also there's been some potential for helping overall patients with dry eye. The idea here is that limiting those vessels that are causing the inflammation, the heat from the laser, also loosening the oil, and then also promoting kind of better health of the oil glands. So what's coming down the line very briefly before we close for the evening, but there's one medication here, which is a RASP inhibitor, which is kind of a new way to approach dry eye treatment. The initial study, the FDA was asking for more data. So there was a lot of excitement with this new potential, but it looks like more work and research needs to be done. But potentially in the future, it might be able to be available depending on how the future trials go. There's a thymosin beta medication. So this helps with regenerating peptides that are kind of, we know that happens elsewhere in the body, but kind of targeting it for the eyes. There's been a few clinical trials, and in the initial ones, they did find a statistically significant improvement in the sensation of giddiness after 2 weeks. So this may also, in the next few years, become available. Another potential drug that's under research, TRPM8. And so with this, it actually stimulates the cold sensing receptors on the ocular surface and cornea. And so the idea here is that it actually induces kind of a cooling sensation on the eye. So maybe in general good for treating ocular pain, but especially with dry eye, people with burning and irritation and foreign body sensation, may be a good symptomatic treatment for patients with dry eye. This medication from Azura Ophthalmic is one of the first kind of ideas of paralytic for meibomian gland dysfunction. So it's an idea of actually targeting the thick oil secretions and breaking them up so we get better kind of flow of the oil. But once again, a topical treatment instead of the procedural based treatment options. So this is one to kind of have a look out for that may be available in the next few years. Another medication coming from Mitotech. This is a cardiolipin peroxidase inhibitor. And so this really goes for targeting inflammation. And this receptor that it binds to is found on the cornea and the conjunctival surface. And so the idea here is potentially improvement with dry eye. Their initial studies did show improvement in the dry eye staining on clinical exam findings. So but another kind of new idea of approaching dry eye. Glaukos has a medication that they're working on, which is kind of more of a cream-based drug that you apply around the eye and it works its way into the ocular surface. And so this is kind of a medication we've actually had around for a long time, but not really thought of it for dry eye. But it's basically similar to pilocarpine, stimulating kind of the secretion of the tears and the aqueous component. But once again, not something you have to instill on the eye itself. It's a cream that goes around the eye. And then the list keeps going, different approaches, different medications, and combining kind of other techniques. I think looking at hormonal treatment, so actual eye drops that have whether it's testosterone or estrogen to kind of target kind of the hormonal effects of dry eye, that's an exciting one. And secretagogues, this is a totally new kind of idea of treatment where stimulating the goblet cells, which are making the mucus part of the tears, and that's something we've not had any treatment options ever available. And so a lot of things coming down the pipeline there. So I think the difficult thing when it comes to dry eye that can really help, but we don't like to talk about it or it's hard to treat is actually behavior modification because we can use all the drops and whatnot, but with society and where we're going, we are using more and more screens, which is making our dryness worse. It's reducing that blink rate so we don't blink as much or we do an incomplete blink. And then also lowering kind of the ability of our oily component to refresh the surface of the eye. And so when it comes to screen time, highly recommend, the 20-20 rule. So that's like every 15 to 20 minutes that you're on the computer, you take a break for 20 seconds, look at something 20 feet away, blink, and then look back at the monitor. Also using the lubricating drops when you're at the screen, because that's when the evaporation is happening and it's at its worst. And then, potentially for adjusting the height and brightness of screens to kind of help promote better blink And then the other idea is we have so much with AI and technology where, our phone can warn us when we get in the car, it gives you that warning like, hey, you shouldn't be using your phone, you're driving, but kind of potentially using technology in that ways to remind us, hey, you've been at the screen for 20 minutes, your eye, whether you're using kind of receptors on the phone or technology we're using to give us feedback to let us know our dryness is getting worse. And whether it's taking a break and blinking or using some lubrication. But these are kind of ways we can make a big impact when it comes to patients suffering from dry eye. So what are the take-home points from this evening's discussion? The field of dry eye is growing fast and it's really hard to keep up, but there's a lot of exciting stuff coming out. The role of inflammation, especially when the diagnosis is made of dry, is very important. We talked about the combination treatments of the new cyclosporin, also with anhydrous lubricant, which kind of helps treat both ends. And then also all the other kind of potential drugs that may be coming down the pipeline and being available. And then not forgetting that behavior modification is very important. And then my last slide is, if you really want to treat dry eye, I would recommend hanging out with a newborn. So this is my son. He was actually born 2 days ago, and he's been simulating a lot of tear production for me. And so it's our first child, and we're super excited. And he's been a blessing, and we're so happy to have him around. So that being said, that was the kind of prepared slides for this evening. I'm not sure, Dana, if we have time for addressing the questions if they've come throughout the presentation next.
Hi, Dr. Behshad. Yes, great presentation as always. There are several questions in the chat. I'm happy to read them to you and you can respond or you can read them.
Sure. I think I can start. So I see one here about Tirvaya. I kind of gently hit on this, but the comment here is that Tirvaya is great, but it's $700 a bottle. It's not affordable. 100% agree with you. And so it's actually very difficult to even get it to the approval phase. There's a lot of prior authorizations back and forth. And this is something we deal with a lot with the different medications because each insurance plan has different requirements and what they're willing to cover and not cover. So this is another important part when it comes to the treatment of dry eye is that the overall cost. It's a lot of work to be putting in these drops. A lot and often, but then to be able to afford it as well. And so hopefully by more and more people becoming aware about this and the importance that we see when we properly treat dry eye, this will kind of help on that end. The next comment is Xiidra and Restasis burn my eyes. So one of the things I like to do is I like to try all the drops myself on my own eye. So one of the things is when the ocular surface is very dry, any sort of kind of medication drop you put in the eye, it's going to burn. And so for my personal experience, when I used Restasis, I didn't have much burning, but with the Xiidra, this was the Lifitegrast is the generic name for it, but this basically was the drop that lowers inflammation and stimulates tear production that works much faster. For me personally, when I tried that drop, there was actually a little bit of burning I had with that drop. And then also my vision kind of got blurry after 5 minutes of using it, and then it went away. And then I also was sensing kind of a metallic taste in my mouth. So all of these eye drops, they have potential kind of side effects. The good thing is none of them are very serious. But I will say I have tried Vivi, which was the newer version. So it's higher dose Restasis, but it has that anhydrous carrier molecule with it. And I didn't have any of those symptoms. So the idea here, and I'm getting that feedback from a lot of my patients, not all, but a good number, is that they're able to tolerate the Vivi better because it's got that anhydrous lubricant. And then with it being higher dose, we're getting a better response. Next question was, what about Mibo, which was that PFHO medication that we talked about? And also with Vivi, it does have that same kind of anhydrous molecule in it too. So Vivi is basically like strong dose Restasis or Cequa with Vivi in combination. Next comment is Vivi is expensive. Yes, there are different coupons to explore in different mail order pharmacies where at least for the first year, you may be able to get a coupon to help cover the copay. But once again, this is going to be dependent on what your insurance plan is, what they're covering, what they're not willing to cover. The next is, can you address severe drying while sleeping? which for me is seen every time I open my eyes when waking from sleeping. Seems very sand-like. Yeah, so kind of going back, we kind of briefly touched about that, but sometimes some people, their eyes don't fully close, and so their eyes are dry while they're sleeping. Or some people, for example, need a CPAP machine, and so the CPAP machine is needed to provide oxygenation while you're sleeping, but it's blowing air in the eye and it causes dryness. So in this kind of situation, kind of back on the conventional treatments, something like using a thicker tear or gel or ointment can kind of help soothe that area and keep that from being an issue. But if it's something chronic, potentially taping the eyelid shut when you go to bed, using like a night pad to kind of keep the eyes closed. Additionally, there are some potential eyelid surgeries that can be done to kind of help with that. So you mentioned Optase. This is a over-the-counter treatment option. Next is for Demodex mites. Is it okay to use over-the-counter lid scrubs? Some have tea tree oil. So before Xdemvy was made available, the only option we really had was tea tree oil. And the thing there is, if you can tolerate the tea tree oil and continue to do it over time, using it can help reduce, potentially eliminate those mites. So yes, if you do have Demodex blepharitis, it's great to use the tea tree oil specific washes and wipes. Next question is about LPR, silent GERD, and dry eye. I don't know of any association there. I use lubricant eye drops, preservative free. Should these be refrigerated? I think that you mentioned autologous drops that need to be refrigerated. So with the preservative free, it depends. So historically, they came in little vials, and once you pop the top, probably after 72 hours, not good to continue using them. But now they do make preservative free eye drop bottles. And so basically the flow is in one direction, and that's how they can get away with having a preservative free option that's in a bottle. So that you just have to double check, because most eye drops that are in a bottle do have preservatives in them, unless they say on the bottle that they're preservative free. Another go-to for Optase, and is Xdemvy expensive? So it's just going to depend. A prior authorization is required. It has to do with, copay, deductibles, and what your insurance covers. We've had good success with some of the mail order pharmacies with that. Next question is, I have conjunctival chalasis and the use of sodium chloride hypertonic drops and gel. Is it likely I could have dry eye also? So conjunctival chalasis, unfortunately, we don't have time to talk about all the different pathologies, but conjunctival chalasis is just excess conjunctiva, or the white of the eye. And so, yes, it can lead to dry eye or worsening dry eye, because you imagine every time you blink, the tear film doesn't fully coat the surface of the eye. And so if the conjunctival chalasis is making the dry eye worse, we do have a surgical procedure we can do to tighten the conjunctiva and help with that. For the home heat, you're gonna, depending on who you talk to, it's all over the place. For me, I think 5 to 10 minutes is a good amount. And that's with the heat compresses to kind of simulate the oil being less thick. So there's a question about where being able to tolerate contact lenses and dry eye. And so, yes, I mean, if the dryness is improved, likely be able to tolerate contact lenses. The other consideration would be, there's a lot of work to kind of get things optimized to then be able to tolerate, for example, regular soft contact lenses. But one of those options, like the scleral contact lens, going to someone that does do those fits, to consider that, because you kind of knock two birds with one stone, treat the dry eye, but then also have the visual improvement there. All right, I think we hit all the questions. Thank you, everybody, for joining us. And
Dr. Behshad, sorry, you missed one, and that was about the gel. There was a question, hold on one second, about using a gel at nighttime. Let's see. It
is it
says,
good to
is it
use
good to
liquid
use
gel
liquid?
nighttime
Yeah.
dry eye therapy, or doesn't it really? Yeah, so I think definitely if you're waking up in the middle of the night, your eyes are dry, in the morning your eyes are dry, or you have one of those risk factors where your eyelids are not fully closing, things like the gel drops or the ointment drops do help. So I would recommend it. Thank you, everybody, for
Any
joining
other
us.
questions from anyone? Thank you.